just make sure, I thank everybody that came today. I truly appreciate you taking the time to read the book and participate in all the different book reads we've had. This has been great. That the Cortland Free Library, Jen Grady, we've done 2 book reviews already. We've had some nice turnouts, some great conversations definitely coming off of that. That's something Paul said earlier, is that this book has really provoked some great conversation, which is what I've enjoyed. So as far as the Zoom stuff, folks, there is going to be chat monitored. Thank you, Aster and Sarah, for that. And if you got questions, they can read them if you don't want to unmute and do it. If you'd like to talk, just raise your hand for us and we'll keep an eye on that too and go from there. So if you can make sure you stay muted. Like me, I have quite a few birds and dogs here, so I try to lock myself in a room so I'm away from them, but I will mute when I'm not talking. And at this point, I'd like to introduce. I mean, it's a great honor for me and a pleasure. I'm ecstatic to be able to do this with Maia Szalavitz here. She is an amazing human being. I'm going to say that first off. We've done over 130 books in our community out through other organizations, and one day I had 20 plop on my porch, and they came from Maia to help the cause to get this tool out and help educate some of our community. So she's a reporter, author, focuses on public policy, education, science, and addiction treatment, and is the author of our book, which you probably can't see due to my thing, but it's Undoing Drugs, as you all know. So take it away, Maia. Thank you.
Oh, thank you so much for having me, and I'm really honored and delighted to be here as well. I'll just give you a little bit of background about why I decided to write this book and what the process was like for me, and then I'd really just love to do questions and answers, because I always feel better as a speaker when somebody asks me something, because then I know at least one person is interested in that. I will start by saying that I had been thinking about this book for a long time, and there were a lot of people in the field of harm reduction that were like, I'm going to write a history of harm reduction, and nobody ever did it. And when I thought about it, I was kind of like, oh gosh, well, it's going to be so much work. There's going to be so many people to talk to, and there's so much controversy, and so many people disagree with each other, and everybody's going to hate me, and it's going to be a nightmare. But since nobody else had done it, I figured, okay, it really does need to be done. I believe it's an important social movement and has done an enormous amount of good for people who use drugs and the people that love them. And so, all right, I went and did it. And yes, it was hard, because when you're doing a first history of anything, especially if you're not even an academic, professional historian at all, it's kind of like, okay, so you have to interview a million people, and lots of people forgot stuff, or well, this happened at some time, but somebody else said it happened at a different time. This one hates that one, and oh yeah. So but I feel like I came to a happy medium where I was able to tell the story of a few key activists. I felt terrible about all the people I had to leave out, and I still feel like there should be further histories of specific areas, like harm reduction in the Black community, harm reduction amongst women, harm reduction, in Australia, all the stuff that I really couldn't do or get into any level of detail, psychedelic harm reduction. I feel really glad to have done it, and I'm really pleased with how it came out. I think, given the timing of it was also kind of interesting, because the pandemic obviously happened, and suddenly everybody was saying the terms harm reduction, because there were, we didn't really have anything else we could do. Like, you can't just not socially interact at all. So people had to come up with ways like masks or distancing or whatever it was, so that, you could reduce harm, because again, social contact is like essential to human well-being. And so, we slowly worked on that, and we took from the people that had originally learned about this during AIDS. And so it was really kind of amazing also, over the course of writing this, 2 different things. One, to see how far we actually have come. I mean, it's certainly not as far as we need to go, But, when I first heard about harm reduction, there was like probably 100 people in the world that knew what it was in relationship to drugs. And, it's now a movement of thousands of people. It was in the State of the Union by Biden this year. It's tops in his drug policy, although there's still a ton of funding for the DEA. But it is remarkable to just sort of see how that, how a small group of people changed the world. And it's also kind of amazing just to see how that, plays out, and what we still have left to do, and, what allowed the change to happen, what got in the way, what can continue to get in the way, and so forth. So yes, with that, I would like to just take some questions.
Well, let me throw one out at you to start it off. Oh, I don't know if I lost. There we are. My screen went weird. Can you hear me okay?
Yes.
Okay. So let's start off with what you've seen in communities that have embraced harm reduction. What lessons can the small rural communities like Cortland maybe learn on the movement?
Sure. So I think what it really comes down to is seeing people who use drugs as part of our family, as one of us, not one of them. And when you sort of, once you understand it, once you're like, okay, this is not about like, sort of celebrating people getting high and taking risks. This is about keeping people alive, and helping them, get the best possible quality of life that they can. And, different people have been through different things. We have different genetics, we have different temperaments, we have different neurology. And the way something affects me, it may be very different from the way it affects you. And when we recognize that, we can say, okay, well, people who are using drugs, like, they may have just been born, some of them, with like an oversensitive neurology, so that like everything impinges on them in a way that it doesn't for other people. And that's why they can't just, do like everybody else does. And so understanding that helps communities embrace it. And also what I think, when you actually see harm reduction in action, and you see somebody who is a person who, is homeless and has been kind of despised by the community and left out and just seen as a non-person, when you can sort of see that person respond to being treated humanely, it's just kind of a spiritual thing. It's a really wonderful, it just like, it's like all kind of good actions. You say, humans are capable of good things, and it lifts your spirit. And then you can see people change in relation to being treated kindly, because people live up to or down to your expectations of them. And so it is really important to have good expectations, and to see people as valuable and capable. And when we focus on people's strengths, you can see remarkable amounts of change. And I mean, just from my own experience, as I described in the book, when I was using, just like being able to clean my needle and protect myself, sort of made me feel more empowered than I had been. It also made me really pissed off and wanting to change things. And that really sort of helped eventually begin my recovery, but it wasn't for another 2 years. And during that time, I was able to stay safe by using clean needles. And, I'm very fortunate that I wasn't in a time when there was like fentanyl in the supplies the way there is now. But still, I lost a couple of friends to overdose back then. I mean, it was never safe. And so, just sort of seeing that we can, that, change isn't as fast as we would like it to happen. And, people are also sometimes jerks, but you can really, if a community embraces this approach, it's embracing, radical empathy or love or just care. Because I think most people, if it comes down to it, do we care more about stopping people from experiencing euphoria or stopping them from being hurt? I think most of us care more about stopping people from getting hurt. And, yeah, we might not like it if this one has unearned pleasure or whatever. And, we may be grumbling because like they're having fun and we have to work or whatever it is. But the reality is that, we generally want good things for people, and we generally don't want bad things to happen to them. And, harm reduction just embraces that, as opposed to this very moralistic idea that if we just are horrible and cruel to people who use drugs, then nobody will use drugs and all will be well. I cannot hear you.
Oh,
It looks like you're muted, Dean.
AJ's got it. Go ahead.
okay, great. Thanks. Hi, everyone. I actually live one county over from most of you in Tompkins County. I lost my son to an overdose, to fentanyl poisoning is actually more accurate, July of last year. When that happened, we knew we had a tainted drug supply in our community, and we didn't do a public notice. We didn't do so I've been trying to be very active in my community about, learning from that mistake and wanting to push out public notices when we know we have high overdose, an increase in Narcan use, things of that nature. I'm getting some pushback from my community that they feel that there are a number of people wanting the fentanyl, and I don't deny that. I think the opiate world, we've come to expect that in kind of in the supply. But I was just wondering your thoughts on withholding community information for that purpose, and some thinking around that would help.
Sure. So it certainly used to be the case back in my day when there was a super strong batch of heroin around that killed somebody. People be like, oh yeah, I want that. Just because by the time you're using for 6 or 7 years or whatever it is, or 10 or 20 years, you have a really high tolerance. And just to get feeling something is going to take a lot. And so when people did that back then, if a new user did that, they were likely to die. But people who were like kind of old heads, no. And so I don't think that's true anymore. And I think that most drug users are smart enough to know that if something has just killed people, that it's not going to be a super good high. There is so much, frankly, poison in the supply that I do think just having that information is really important. Because if you have that information, at the very least, okay, let's say you are attracted to it, you can at the very least be cautious. You can take a smaller taste, you can do, you can test it, you can do these things that can minimize, you can not use alone. You can call that number so that people can call for help. I'm talking about the Never Use Alone hotline. So I think more information is generally better. Yes, it is the case that some people who are actively suicidal will respond in ways to information that we would not like them to respond to, but they are typically not the majority. And giving the information that could, save people, I think is more important. And I think, of course, we don't want to be advertising it. This is the best drug ever. Come kill people. That's not, I think straightforward information about what happened, and also like straightforwardly being poisoned is not fun. The thing about fentanyl that is, really different from heroin in a lot of ways is that it just lasts for only a short period of time. And so you maybe get 10 seconds of euphoria and then you're asleep. Like with heroin, you could be sort of half asleep for like 4 to 6 hours. And you could respond to things in the environment a lot better, but a lot of this stuff just makes you unconscious. And while there are certainly people who use drugs that do want to be unconscious because their consciousness is just that painful, I think the vast majority of drug users are, they actually want to feel better, not unconscious. And so something that makes them unconscious is going to be less desirable. Again, this will vary by people's moods and people's experiences and et cetera. But I do think in general, having that information is better than not having it. And I think that the people who would misuse that information are a minority.
Thank you.
I'd
That's
like to also, sorry, Dean, I just want to emphasize what Maya's point that, another maybe naysayer or a wall or a barrier that might, you may want to address with communities is what Maya's saying is that, oh, we're going to give them this information and they're going to, they're going to be irresponsible with it when in fact, not only with, fentanyl or whatever, but other types of health information. When someone who knows something about themselves and they have that information, you give them that choice to exercise what they want to do with that information. And for example, somebody who's Hep C positive, right? There was a time when you heard folks, doctors wouldn't treat somebody who's HIV positive, or Hep C positive, right? Why? They won't comply. They can't comply with treatment. All false, completely false. What did we see with HIV infection? Just syringe, give the person a syringe. What did they do? They used it, right? Brand new. So it's saying the polar opposite, to say we're giving people the information they need, even in their whatever drug mind or whatever it is, they're using it to their advantage, right? To be healthier and to be better and to be alive. So it's kind of poking holes at the misnomer of, oh, we're advertising there's this better drug out there. Yeah, everybody already knows it. But we know that people do good things, responsible individual behaviors with that information to keep themselves healthier and safer.
Yeah, I think one of the misconceptions that a lot of people have about addiction that sort of gets generated by this idea that their brains are hijacked, or they have no control of their behavior, or they're totally powerless over everything. This is just not true. People with addiction may have their priorities reset to kind of focus on drugs more than other things, but they're still human beings who can make choices. And generally, if given good information, they will make better choices. And I think, we see that with needle exchange. We see that with the use of naloxone. We see that with a lot of different things. And, you can't account for everybody's reaction to something. But in general, most people will respond to this information appropriately.
That's fantastic, and great answer to that, I think. And thanks, Clara, for that input as well. Jessica, you go ahead and unmute if you want. I see you got your hand raised, and then I see we have another one after that.
Yeah, I just wanted to go a little bit off of what AJ talked about, how promoting it and stuff like that. We do. I'm an addict. I am in recovery. We do seek out what we hear is strong and what is good and who's dying off of it. I don't have an answer for why. I'm just going to say myself does that, but I have done that a lot in the past, which is very scary because a lot of the new people that are trying all of this out, they aren't educated. They don't know what is really going to happen when they get a hold of this stuff. I don't feel like we're promoting it when we say, that it's killing people. It's how the addict addresses it. I feel like it's their own mindset, how they are going to react to that. Now, for me, myself, when I was in active addiction and I would hear, oh my God, so-and-so overdose, I was looking for that. I definitely was on the hunt for that particular drug. And that's sad. And I know there's a lot of kids out there right now, a lot of young kids that are like really getting hooked on this stuff, and it's in our community. We have to not really promote it, but I think maybe put it in different wording, if that makes sense. I don't know how we would do that. I just know that I have children and I know they're experimenting with this and they want to experiment with that. And of course, me being an addict, I have to stress to them that fentanyl is in anything. It's in everything. You can even get it in marijuana now. I
don't think that's actually the case.
You don't? Okay.
There's been reports of that, but none of them have ever actually panned out. So, the police say this batch of marijuana has this, but it's just, it would be a really, really stupid thing to do. Why would you waste an expensive drug on killing your customers?
So, I can go a little bit off that. So fentanyl is very cheap. It's very, very cheap. You can get a lot of it for a very small dollar amount. And if
Well,
you
what I'm
can,
saying is it's not going to actually make the marijuana high better because it will burn up. And so it's just not a good business decision if you're thinking about it from the dealer's perspective. It does not, and I mean, again, people have said that this exists. Nobody has ever found it toxicologically.
okay. All right. So, I know you can smoke fentanyl. You can smoke it. You can do whatever you want with it. So maybe they're not putting it in marijuana as often as I thought they were. So they're putting it in other stuff, and just a little tiny bit. That's really all the dealers are really looking for, is to really pull you in and get you hooked on it. So they don't have to use a lot of it, and they're doubling their profit on it. Because now you had a taste of it, and now you want more of it. And it's just a whole cycle.
I just have to say that I really disagree with that perspective, because for the most part, if you're going to, first of all, most people have more than one dealer. And so if you are going to look at, for example, I'm going to go buy some Coke and I want to stay up all night and go dancing. Now somebody's put fentanyl in that Coke and I'm passing out. That is not going to be good Coke to me, because Coke is a stimulant and fentanyl is a depressant.
Because that's how they speedball.
Right, but that's a different thing. People who are seeking speedballs are seeking speedballs. It is not the case that somebody who is not doing opioids and just does cocaine is going to think, oh, this is great, I want more of this. Also, if they don't know that they're getting fentanyl in it, they can't ask for it. So the other thing that's important to realize in terms of this is that the dealers, people want specific things. Speedballs have been around. I loved speedballs back in the day. They were, a thing way going back to the 50s. But nobody has sold a pre-mixed speedball, even though that's a very obvious thing to create. And part of the reason is because people like to control the onset. So sometimes you want to go up, sometimes you want to go down. You want to know what direction you are going in generally. And so the idea of putting it into something to hook people, the other problem with that theory is that a lot of people who are on cocaine have no idea what opioid withdrawal symptoms are. And so if they started getting dope sick, they would feel like they have the flu. They wouldn't realize that they were having opioid withdrawal because they didn't think they were doing opioids. And so again, it's just, if you branded it, if you said, this is Maia's super speedball, this is the best drug, you want an up and down thing at the same time, come and buy this, then yeah, I could see that being done to hook people. But if you're just lying to people about what your product is, and people are going to seek the thing that they think they're buying, it's not going to be very effective for your business.
All right. I think there's some good information, and as always, sparking good conversation. So Ellie, do you want to go ahead and unmute? I see you got your hand up there.
Hi, my name's Eli. I just can't thank you enough for writing this, for making time for us. I came up in recovery 12 years ago when abstinence only was, let me take my hand down, was the only way that I had ever heard of having a better life. And I just...
Wait, you got muted.
Sorry. So grateful for this forum. And I guess I just wanted to ask a little bit about, if this isn't too off topic, using, instead of always being framed as this really negative, self-destructive, horrible thing, that's an indicator of moral failure and brokenness, as a type of coping, whether it's for mental health symptoms, trauma responses, just living in a effing pandemic and patriarchy and capitalist society. I don't know, but I just like that has been really interesting to me lately. The idea that all drug use is not inherently destructive. And I didn't know if that was something you could speak to.
I'm sure. No, I mean, I think, the vast majority of people who take drugs, even heroin, are not addicted. People who take heroin and cocaine and methamphetamine, people who try them, about 10 to 20% of them will become addicted. And this is trying them in a recreational context, not a medical context. And that means that 80% don't. Now, again, addiction is not the only harm you can experience, because you can be thinking you're taking Coke and somebody put fentanyl in it and you can die. It's, people have used drugs before we evolved into humans. As I always say, cats have catnip. Even though we didn't evolve from cats, but anyway, we have cross-historically, cross-culturally, there's always psychoactive substances. People and other beings have always wanted to alter consciousness, and it's not always bad. Sometimes it's an expression of spirituality. Sometimes it's a painkiller that you actually need. Sometimes it's an emotional painkiller that you actually need. The problem comes when either the drug itself is harmful, or you have compulsive use of a substance despite negative consequences. And so, and that is addiction. I think we should be gentle with ourselves and recognize that, yeah, like nobody wants to be in pain. Everybody wants to, have some relief. There's nothing immoral about seeking that. And I mean, I think the idea, I always hear people about like, oh, you're on opioids and you're totally numb, or, oh, you're on antidepressants and you're totally numb, and this kind of thing. And it's like, no, if your baseline is up here and you're taking something that's bringing you down to here, that's making you more normal, not less. And so if your baseline's here and you're taking something that's bringing you down here, yeah, that's going to make you feel numb and awful and terrible. And this is why, about half of people who try antidepressants, or more like a third, have horrible response to them. And similarly, about a third of people have a horrible response to opioids and don't like the experience at all. They're like, oh, this makes me feel terrible and numb and nauseous and disconnected. Whereas the people who are up here, oh, I feel more connected. So a lot of it really depends on your baseline. And I think, we all use caffeine pretty much. A lot of us use alcohol. A lot of us use cigarettes or marijuana. And, New York is legalizing, so the marijuana thing is going to be here more soon in terms of options for people. And so, I don't think it's immoral to alter consciousness. Otherwise, we'd have to say music is immoral. And I refuse to say that because I love music. I think what's immoral is causing harm to yourself or others. And, trying to cope ineptly, not on purpose, is not immoral. It's just like, you could do this in a better way that would be less harmful. And I think that's really the way to frame it. And I also think when it comes to, the idea of abstinence, like, some people need abstinence, other people don't. The people who need abstinence, it's really important not to have that be the only measure of your self-worth. Like, I have 10 years or whatever, and so you could say, well, I have 10 years and now you slipped and now you have 0. And that's ridiculous. My idea here would be, if you have 10 years and you slip and you get 90 days back, you should get your 10 years back too. Because it's true, you had those 10 years, they didn't just get erased. You had all those experiences, you were, abstinent all that time. And, there's a thing called the abstinence violation effect that comes when people think that abstinence is the only thing worth valuing. And what happens is you have a little slip and then you're suddenly like, okay, I already blew it. I may as well just go for it. I'm going to drink. Now I'm going to do some cocaine too. Now I'm going to, whatever. That can be very dangerous. That can lead to overdose, and it can lead to people not coming back to their support groups because they're ashamed. And so, being aware of that abstinence violation effect and doing things to mitigate it, like, for example, this idea I just said about you get your 10 years back after your 90 days, or just some way of framing it that recognizes that those 10 years counted and that your efforts, like, you're not in recovery because you had a slip. That's just not a good way of framing it. I think that, recovery is a process. I really like the thing that Faces and Voices of Recovery do, where they say, I'm in long-term recovery, and for me, that means X, Y, and Z, because we should define it for ourselves. And for some people, it's any positive change. Today, I used a clean needle. That is my step in recovery for today. Whatever it happens to be, we should celebrate those small things, because when you do that, they can lead to bigger things. And also, all the stuff that we do, even if we're not perfect at it, I think it matters.
You're right. And I love that. Any positive change, 100% love that. Paul, I see you got your hand up if you want to go ahead and unmute.
Yeah, thanks. Yeah. Thanks for being here, Maya. I really appreciate your work, including Unbroken Brain, other works of yours. And what I was most struck by reading this book is just how, based on place and time, we're sort of in different time zones, in the sense of this upstate New York, I can think of as almost 30 years behind New York City, in the sense of that recently we were trying to get a needle exchange and the local government was resisting it. And I don't normally go to local government meetings, but I'm glad I did, because someone from the DA's office was there taking a study that was not peer reviewed and trying to argue against needle exchange. And I basically had to stand up and say, I'm a former drug user. I do think drug users care about things like leaving dirty needles around. Like, if they had a place to put them, they would put them there, right? That I had to try to appeal to emotion because there's such a twisted response to evidence, even among our professionals. And it's just painful. It's really demoralizing to me that we're at least 30 years behind, if not what had been done in New York City. And so I guess I keep wondering about what the next step might be in rural areas that tend to have more poverty, more despair, more deaths of despair, including drugs. And I'm afraid we're getting to two Americas. Yeah, what do you think about that? Sure.
I mean, I think that's real. And I am particularly trying to boost rural harm reduction and harm reduction in the South, where it is like where we were 30 years ago. But the thing that you guys have that we didn't have 30 years ago is the 30 years of evidence that we have produced. And the fact that the CDC now says that, we should do needle exchange, and the NIH says it, and the World Health Organization, and basically even Iran and China, like everybody that has looked at the data honestly says, oh, okay, you add a needle exchange, HIV and hepatitis C rates go down. You take one away, they go up. This is not complicated. Now, sometimes, to be fair, you probably also need low threshold methadone and buprenorphine to ensure that needle exchange is as most effective as possible, because people do slip, and the best way to stop an HIV epidemic is needle exchange and low threshold methadone and buprenorphine. And you can, again, if you just look at the data on methadone and buprenorphine, you add these drugs, you get less overdose deaths by 50%. You take them away, you get more overdose deaths by 50%. So it's like, causality is really quite clear with these things, whereas in a lot of public health, it isn't. But these effects are so large that you can just see them. And so, if you look at the CDC's website, if you look at, DAs should not be speaking about health issues unless they are talking to doctors first. It's just, also, there are some crazy doctors, but let's not go there. But it is just, I saw a letter that I think it was our Attorney General, Letitia James, sent to the CDC, which is revising its guidelines on opioid prescribing because they've done a lot of harm to pain patients. And she was like, you know, you have to have dose limits in there. And I'm like, when did you get your medical license? Like, if the actual doctors, which the actual doctors are saying that, you know, people have widely varying metabolisms. I have never prescribed anything to anyone, but I have seen widely varying individual reactions to different drugs, such that I know, and I also have read the literature on genetics of the liver CYP3A2D6 system, you know, and it's like, okay, some people are fast metabolizers, and I may have butchered that name, but it's a complex liver enzyme system that varies widely genetically. And for example, some people cannot metabolize codeine at all, and it just has no effect on them. Other people metabolize it really slowly, and you could actually overdose because it gets turned into morphine. So it is like, there are wide individual variances, and all you'll have to do is look at, like, here's a little tiny person who weighs 8 pounds. Here's a person who weighs 500 pounds. You think they need a different dose?
No, that's great. I got Clara, you had your hand up. If you'd like to go ahead and mute.
Oh, sure, Maya. Thanks again. I always enjoy listening, and I'm working my way through the book. What comes to mind? Well, 2 comments. One is, I love how you compare harm reduction to the Hippocratic oath. Like, it's like, yes, that's clear, that's simple to me, and it's something that I think, I don't know if I'll ever, I don't know, it just was like, yes. I'm like saying it out loud as I'm reading it. And so that brought me to thinking about how we train providers, non-clinical providers out in New York State. And has anybody spoke to you or approached you about taking parts of your book and converting it into modules or teachable, I don't know, whatever, lessons, for lack of a better way of saying it, so that this type of discussion can happen among providers?
I would love to do that. In fact, I am very much looking forward to speaking to OASAS, which is the Office of Substance and Addiction. I don't know what it stands for.
Yes, something like that. Yeah.
Make it like less stigmatizing, which is good, but I just can't remember the new acronym. Anyway, I'm very, very happy that I'm going to be speaking to them. You must work with Alan.
Yes, I do.
And yeah, like, it was because I did a presentation for Alan, and so the person who heads Oasis was there, and she's like, you should teach this to our people, and I'm like, yes. So I would totally be willing to do something like that. I just, you know, part of the thing is, like, I'm a journalist, I don't like have the credentials, but I would, you know, anything that I can do to help and get this information into the hands of the people who need it. And I do think it's very sad that there's a lot of people in the field who've basically been miseducated. And, you know, there's sort of so much information out there, and I hope I wasn't mean before, I feel bad now. But there's so much information about there that people have that just isn't supported, that, like, we just pass on because everybody has said. So it's something that I really care deeply about and would really like to do. So if you have any ideas, please let me know.
Absolutely. That's great. That's great. Thank you.
We have a couple questions in the chat that I think might work well together. Earlier, someone had asked, as a decision maker in my organization, how can I take a few steps to be more aligned with harm reduction? And then somebody more recently said, I have family and colleagues in law enforcement in the medical field who still roll their eyes and scoff when I say harm reduction. How can we continue to reach across the aisle to educate those who see this evidence-based approach as a type of enabling? So I'm curious about sort of.
Let me start with the second question first. So the concept of enabling is simply not supported by the research. Because if you can prescribe free heroin to people and they will not stay in active addiction longer than the people you leave on the street and don't provide free heroin to. So if providing free heroin isn't enabling, I don't know what would be. And so given it's just not supported. Like the idea that we give people, we're nicer to people who use drugs and then they're going to use drugs longer and they'll never, discover the joys of recovery. That is not how it works. Addiction is defined as compulsive drug use that continues in the face of negative consequences. And this is not just Maia's random definition. This is like NIDA and the DSM. So, if you Google NIDA's definition of addiction, you will see what I said with the addition of brain disease, which I don't want to get into right now. But the point is just that the essence of it is that it does not respond to punishment. Fundamentally, it does not respond to negative consequences. Now, can somebody hit bottom at some point? Yes. Then they can also relapse 2 weeks later and have a new bottom. And then they can relapse 10 years later and have a new bottom. So the only way you can define bottom is retrospectively, which means it's a narrative device, not a scientific one, because you need to see things prospectively if you're going to actually research them. So what I mean is just that, we think that if we're nice to people who use drugs, they will use drugs longer because their lives don't suck as much as they should. The research, whether it's needle exchange, heroin prescribing, overdose prevention sites, naloxone, none of it shows that it extends people's time out of treatment. What it does, in fact, even with heroin, you see increased admissions to more traditional forms of maintenance and abstinence. So basically being nice to people serves as a bridge to treatment for a lot of people and to recovery for a lot of people. And sometimes that recovery looks very traditional and sometimes it doesn't. But what you do see is people's lives get better and they don't die, or they die less. I mean, this is the other thing about harm reduction. It reduces but does not eliminate harm. And, much as we would like there to be harm elimination, that does not work in the real world. When you try to be extreme, the best becomes the enemy of the good. And then you end up doing things like, we're going to make it as bad as possible so that people won't ever do this. And then, of course, the most vulnerable people do it and they die and they don't prevent anybody else. And this nonsense continues. What was the first question? Because now I've forgotten.
Sorry, it was about how someone in a service or community-based organization as a decision maker can take a few steps to sort of align more with harm reduction.
Sure. So, I mean, I think it's a way of thinking and a philosophy above all. A lot of people are saying, oh, it's needle exchange, or, oh, it's naloxone, or whatever. What it really is focusing policy on saving lives first and not worrying so much about if people are using or not. Worrying primarily, how are these people doing? And first, because, sorry, I just lost track of what I was saying, but anyway, understanding that it is a way of thinking, you can apply it to, whatever's going on, whether it's like using a mask for COVID or, wearing your seatbelt or, and just sort of, it's about recognizing that whether we like it or not, people are going to engage in risky behavior. And we can either make it harder for them in a vain attempt to prevent others, or we can save their lives and, try to deter people by better means. For example, if somebody has an extreme risk-taking personality, helping them learn how to manage that, as opposed to, well, we're just going to ignore the fact that this person always likes to jump off cliffs. And I mean, the thing is, like, a lot of this stuff you can see in little children. You can see the person who's oversensitive, the person who's a big risk taker, the person who's really anxious. These are the traits that, if left unaddressed, will often lead to risk for psychiatric disorders. Anything on the extreme may do that. And so if we know this, we can help people who are on those extremes modulate them so that they can be safer. And I mean, for me, if I had known that I was on the autism spectrum, instead of thinking I was like a bad, horrible person who was selfish, I might have avoided the addiction entirely. Again, and the problem, of course, is that different people react different ways to different things. So I could have been told that and then thought, oh, I'm still horrible. But The point is just that if you look at it as an overall philosophy and just think about it in your daily life, like, what can I do to make this situation better for other people and healthier for other people? When you start thinking that way, it's really amazing because it can help you. And it's kind of funny because when you think about, the 12 steps and the moral instruction in those and moral inventory and all this kind of stuff, this is kind of does that in a different way, because it's like, you're thinking about how can I be less harmful? Which is also kind of how can I be a better person? So I think it's useful that way. In terms of practical stuff, though, I think being educated about the fact that this enabling concept is not accurate, and that understanding that there's overwhelming data in favor of needle exchange is probably the best supported intervention in public health, and just sort of understanding that, like, there's this huge body of literature, here it is, and this is why it works. And also understanding, people's emotional responses, such as the, oh my God, it's enabling kind of thing. Because it does take a long time to sort of dismantle this programming that society has given us about what addiction is and about, what works for it. Because from pop culture to, like, high culture to wherever you see stuff on addiction, it often is, misinformation. And, there's a lot of people who think, like, oh, everything I needed to know about drugs, I learned in DARE in 7th grade. And they don't realize that they don't know what they don't know.
No, that's great. I want to just add, because, asking how you break that barrier with law enforcement and, the other people. So I mean, I'm going to say we have a few legislators here, which I'm grateful took the time to join us. I do see some other county leadership here. And I think that this book, I wholeheartedly believe this book is a great tool, and getting it in the hands of people so they can read it and use that to kind of maybe help educate them. The barrier there is whether or not those people want to be open-minded enough to rethink what they've been taught. Now, with that said, there's somebody that's on here, and I'm not going to throw their name out, but they can raise their hand if they're okay with me bringing them into this. But they spoke about an inner struggle in one of our talks. And I really liked the way they worded it. And it's a great explanation. And that's the biggest barrier that we're going to face when trying to educate them, is because they're already set with, this is what it is. This is what I was taught. This is what the law is. And they have to be open-minded enough to look at the other side and see what 30 years of facts are showing them. If the other person that's spoken that wants to say yes and come in and explain that, that would be awesome. But I did see also that Alex, at one point you had raised your hand and threw something in the chat. Do you want to go ahead and bring that up?
No, I was just commenting that I really loved the book and your ability to talk about your lived experience, and how that interacts with all the other aspects of personality and of disability and culture and, location and all that. So I just appreciate that, because we often look at, like, we say, oh, those, druggies or whatever horrible term, instead of saying, like, oh, that's a person that has all these different intersecting things. So we're hopefully a part of helping to support people that are going through a challenge, or learning to live with their disability.
Yeah, and I mean, I think, the insights from the disability community more broadly are really helpful for this, because, some of the sort of ableist stuff that we see, and I can say, like, I've been guilty of this myself. It really, because, like, when you're sort of trained, like, as a kid, like, to think that smartness is everything, you can really get yourself in trouble with this. But when you realize that, no, we're all valuable and we all have different things to bring, and that when you make room for people with disability to have less disability, everybody benefits. I mean, I always love the example of, you put those cuts in the sidewalk for wheelchairs, and suddenly people with strollers can, like, move around more easily, you know. And the thing about disability is that, you know, almost all of us will experience some of it when we get older, if we are lucky enough to get older. So, you know, so it's, you know, you can sort of have your own little selfishness about being good about this. And I think, you know, it's really, I want to say too that I think one of the most powerful ways to make change is to talk about your own pathway. Whether that is like, I mean, I can't remember if this is in the book or not, but I once wrote this op-ed opposing methadone treatment because I thought I was replacing one drug with another. And obviously, I completely disagree with this perspective now. And I probably spent the last 30 years showing that I disagree with that perspective. And the reason I disagree with that perspective is because dependence is needing something to function, which is what happens when you are on, you know, medication treatment in some instances. That is very different from compulsive use despite negative consequences, which is addiction. Sometimes you would have both addiction and dependence, as in an active opioid person with opioid use disorder. And then that same person can be in recovery, taking the same steady dose of medication every day, even though that medication is itself an opioid. And understanding that people on medication treatment who've been stabilized are not, you know, I could be on a dose of morphine right now or methadone right now that could kill you, and I would still just look like this if I was on the right dose for me. So it's really, you know, when you drive or whatever, I actually can't drive, but people can drive. But you know, you can do the things you can do just as well once you're on that and you're not emotionally disabled or any of this. It's again, back to that baseline thing. If you're starting up here and you need to be here, something that brings you a little bit this way is going to push you in the direction that you want to go, as opposed to the wrong direction. And so understanding the way this works and how individual differences intersect, including stuff to do with race and class and gender and all that, is really important. And we can, you know, I just think when we realize like how much human potential is wasted by just throwing people with addiction away, you know, it just breaks my heart. And this always strikes me whenever I talk to people who are, you know, unsheltered or, you know, in other severe situations of distress, often involving active addiction. And I talk to them and they're just people and they have stuff to say that matters and stuff to give that we are wasting by not helping them. You know, and so like, I mean, it sounds corny, but I just feel like the whole society would be better off if we could take advantage of the gifts of all the people instead of like just saying, oh, some of these, you know, we should just lock them in a cage and you know, we'll let other people make money by like oppressing them. You know, so I think it's really using that disability studies, et cetera, lens can be very helpful.
That's awesome. Bo, you want to jump in? Go ahead, unmute.
Sure, happy to. Thanks, Dean. Maia, I really appreciate the book. I'm a Cortland County legislator here, and you know, the discussion that you were talking about a little bit earlier with regards to enabling has been something we have run smack dab into the middle of on the legislature. You know, just about a year ago, I think, it's been pretty recent, we were just able to finally get a syringe disposal box installed on county property. And that step took a lot of effort just to get to there. And Southern Tier AIDS program and others really helped us get there. But a lot of the pushback was, well, if we put a box in there, then we're telling people we support, you know, using drugs and that sort of stuff. And no matter how many times we told them, this is for any needle, be it your grandmother who's a diabetic, to somebody who's taking a biologic, to somebody who finds a needle on the street and wants to properly dispose of it. It's just getting rid of a syringe that's in our community. But, you know, that was a step too far for others. And then we constantly are fighting this 1980s Nancy Reagan mentality of don't do drugs, don't do drugs, don't do drugs. And, you know, it's been, particularly those of us that are Gen Xers, it's been beaten into us, you know, since we were kids about this. And every little step is this idea that if we do anything to support, we're saying as a community, we support you doing that activity, and we encourage you to do that activity. And what's been really helpful with this book, and I am hoping my other fellow legislators, I know Doug Bentley's on the call and there are others, will take that and read it and understand that harm reduction is about help. Like you've been saying, it's not about enabling, it's about getting people through a bad period of their life so that we can keep them around and be functioning parts of our society all the way through, and that we don't lose them, because we lose every opportunity for their future involvement in our community once they've passed away, if we've missed all those opportunities. And that's what I think, you know, Dean and his group have really been pushing, and your book really helps highlight, is every chance we have to connect is a chance to break that cycle, even if it's just for a week, even if it's just for a day. It's another opportunity. So I've really appreciated this chance. I don't have any questions. I'm trying to just mainly listen, but Dean has been great about kind of pushing it over, because I know I don't know what I don't know, and I appreciate all the information to help me on my journey to move things along. So thank you.
Yeah, thanks. The other thing that may be useful when you think about enabling, in what other condition do we want to disable people? Right? I mean, and the other thing that is deeply problematic around that idea is this idea of codependence. Well, first of all, addiction is not dependence, as we were just saying earlier. And humans are interdependent fundamentally. We need each other. No baby can survive without, you know, being nurtured. None of us, you know, hermits do exist, but it's not healthy. You know, our biology is all about, our stress systems are modulated by our connections to each other. And I was just reading a study about how during the pandemic, people who had relatives in ICU that they couldn't see are twice as likely to get PTSD compared to people who are able to visit with their loved ones. And that's like, that says it all right there. And I mean, it's obviously even worse when the trauma occurs for a child. When we sort of understand how these things interact with each other and how people, you know, actually operate, in what other condition do we stigmatize parents for wanting to help their children? Like, you know, yes, somebody may be helping their children ineptly by, say, throwing them on the street, or by, you know, doing things that are not productive, like screaming at them. But that doesn't mean they don't love them. And that doesn't mean that they have a disease called codependence or are pathological in any way. Like, I mean, you know, if you don't help your relative with cancer, you are seen as a bad person. If you do help your relative with addiction, you are seen as a bad person. This makes no sense. And so we really need to just uproot these concepts and just recognize that, you know, being nice to a person and helping them move towards change is not saying, I think everything you do is wonderful. And I love that you're shooting up. You know, it is just saying, I believe that you are a good person and I want you to live. I'm not happy about the shooting up part, but I don't want you to die. And, you know, and that's the other thing, is when you have that attitude towards somebody, that person is so much more likely to change, because it's not a power struggle anymore. It's not about like, oh, my mom says this and like, I can't do this because they don't want me to have any fun or have any pleasure, or, you know, they want to run my life or whatever. If you're saying, I just want you to be okay, you know, and you're coming at it from that perspective and be like, you know, I would love you to try treatment. If it sucks, we'll try different treatment. My point is to have you be healthier and happier. I don't care how. So if this program is nasty to you, we'll take you to another one. And when you get that kind of rapport with the person who's affected, it's so much easier to get them to get help. I mean, the vast majority of people will get help if welcomed into it, as opposed to being kicked into it.
Well, I see we have a question down there in the chat. Says, what does the future of harm reduction look like in the US in your ideal world? Now, Maya, I know that you were planning on only an hour, so I don't know if you're running out of time and you got to run, or if you're good for this.
I can totally answer this one. And really thank you so much for having me again. But okay, so what I would like to see, and it was really funny. So I was on a call with Nora Volkov, who's the head of the National Institute on Drug Abuse. It's the biggest, it's part of the NIH, and it's federally funded agency and the biggest funder of addiction research in the world. Anyway, she asked me this question. So her being the person who's in charge of funding all the research, I said, well, the first thing I'd like to see is a heroin trial or a trial of Dilaudid for safe supply in the United States. Now, we already know from the data in other countries that this can be effective, but we're the United States, so we have to prove it in Americans first because we're so different. So anyway, I hope I didn't piss her off too badly, but I think she actually wanted me to say that. So that's one thing. I would really like to see decriminalization of all drug possession. We have absolutely there is no positive that comes from arresting somebody for possession. It doesn't get them into treatment. We can leave them with a criminal record. It exposes them to trauma in incarceration. It exposes them to people who have more and better drug connections in incarceration often. I have heard more than one story of people whose first time shooting up was in jail. And, if we can't even keep drugs out of jails, then it's kind of silly to think we can keep them out of the country. So I think understanding, that that criminalization, all it does is generate stigma and spend hundreds of millions of dollars that we could be using to effectively attract people into treatment, which will be much, the thing is also when you're not forcing people into treatment, the treatment has to become nicer, and nicer, more gentle, more kind, more empathetic treatment is more effective. So by taking these harsh elements out and by sort of using basic capitalism, i.e. if you have to compete for customers, you got to be nicer to them, then, we can get somewhere. So decriminalization of possession, I would really like to see. I'm really glad that it is happening and that they are moving forward in Oregon. I know people are like, oh, it didn't work because we don't have treatment for everybody already. Well, the grants haven't even been delivered to the funder. It's like you expect this in 5 minutes when you have one of the worst treatment systems in the United States, and the United States system is bad. Anyway, moving forward with that, I think, it's just an enormous waste of money, and it doesn't deter kids. Like if it had been deterring kids, we wouldn't be sitting here having this conversation right now. And in fact, there's studies that show that like the number of drug arrests in a particular city or state or country is not associated with the level of overdose deaths or the level of drug use. So it just doesn't work. Now it's a much more complicated discussion around dealing, which I think we can bracket for now. But the main thing is I'd like to see decrim. I would like to see people have access to safer supplies through the medical system, like prescribing heroin or Dilaudid or other things like that for people for whom methadone and buprenorphine and abstinence treatments have failed. It works very well that way in Europe. We can do a lot better with stimulants than we're doing now. I've heard about a very interesting experiment in San Francisco where what they're going to try to do is have a sobering space for people who are actively on stimulants. So, because a lot of the craziness that comes from stimulants is people get paranoid and they're out on the street doing weird things, and that scares other people too. And it's, not pleasant for anybody. If you have a place where they could go that's calm, that can help mitigate that. So that's a sort of interesting new form of harm reduction that I am eagerly awaiting hearing more about. Obviously, safe injection spaces are a good thing. My feeling is that they will never be a solution for rural areas because you would have to drive to them. And people don't usually go very far to once they have their drugs and they want to use them. They want to be, where they are. So, in places that have really concentrated drug use and drug sales, they can be very helpful. But that's to just sort of help people get into services and stay alive at that point. But we're just not going to have one on every corner. It's not realistic. So I think the bigger fight is to allow doctors to prescribe safe supply to people. And also, I should say, stop cutting off the pain patients, please. Like, if somebody's stable on opioids, like, cutting them off is more likely to kill them than it is to help them. If somebody is having issues where, the opioids aren't working for their pain or whatever it is, you can work with them to see if a lower dose would be better for them. But if you just impose it on them, you're likely to drive them to either the street or suicide, none of which reduces harm. So stop cutting off pain patients, provide, medical safer supplies to people who need them, decriminalize, and continue looking at innovative ways to, because I think, like the sobering thing for methamphetamine, that comes from the street. Like, people on the street thought of that. And if we can be creative, we can do a lot more and, help a lot more people, I think.
Absolutely. And like right now, Cortland, the healing study that we're doing through Columbia, the Columbia study nationally done, we're one of 16 counties in New York. And the great thing about this is we literally have a chance right now as our community to engage in new things and help formulate exactly the things you're talking about and bring change to an entire country. We have that opportunity if we can bring everybody on board and try new things. So, but I don't know if you got to run.
I can just say one more thing here, which is that when I was speaking to Nora Volkov, she was interviewing me for a conference of all the investigators in the HEAL program nationally. And so I'm glad that you are one of the cities that is doing that. And so, yeah, like, I think also, when you're trying to have people change their ideas, showing them real world examples of what it looks like Portugal or, stuff closer to home, ideally, you can see, wait a minute, like, they did this and the sky didn't fall. They did this and it actually worked better. Okay, let's see what we can do with that, because when you see a town similar to yours that has done this and, it didn't lead to, mayhem, then you can, then it's a lot easier to say, okay, like, maybe the stuff I learned about enabling wasn't right, and we have paradigm shifts. I mean, one of the things I really learned when writing the book was that, our Gen X days in the 80s and 90s, if I had tried to publish this then, like something like this, like, it would have just been seen as massively fringe. You couldn't imagine Joe Biden, who was like the guy who was like really gung-ho about the drug war, actually like supporting harm reduction. Like, that was just not a thing that could be imagined at that time. So while we definitely have a long way to go, I do think there's actually a sea change. And I think it's driven by parents and people with addiction themselves who have had horrible experience with what's wrong with it now. And so I really applaud you guys for doing that. Thank you. Thank you very much. I see there's a lot of comments in there with a lot of people thanking you for quite a few different things here. I appreciate your time. I really hope that you and I get to continue to do more like this. Especially when you said providers, I now have a new mission. So we're going to talk about that. I know Sarah will help. If anybody doesn't have any other questions and Maia is all set, I can't thank you enough for your time. And the book is just phenomenal. It really is. It's a great tool. Thank you so much. And yes, we will be in touch. All right. Thank you. Thank you, everybody, for joining us.